Hi, it's Dr. Centeno, and thanks for joining us today on You've Got the Power. Again, our goal here is to educate patients and to make sure you're informed about lots of different topics. Now, today we'll talk about the differences between prolotherapy and PRP when it comes to ligament healing, especially ligament healing in the neck. And the goal here is to try to help you differentiate what those two things are, how they're similar, how they're different, learn a little bit about how those are applied. And again, the end goal is that you understand what different things are out there, what their risks are, what the possible benefits are, so that you can make informed decisions about all of this stuff. So we're going to start, as we usually do, with a little bit of a very short lecture, maybe 5-10 minutes. And then you can ask any questions you want, whether it's about today's topic or another topic. Again, if you're just joining us, we're going to talk about the differences between PRP and prolotherapy, how they're different, how they're similar, how they're used, et cetera, et cetera. So we're going to go ahead and I will share my screen first, and then we'll start that presentation. Looks like that worked. And we'll get the presentation going here. So today's topic is PRP versus prolotherapy, and in this case to treat cervical instability, but it really could be anything. We could be treating low back pain or SI joint instability or a bad tendon. These concepts are really the same. So I've covered various iterations of this talk and various answers I've given through the years on this show, but it's worth reviewing because I still get these questions on an ongoing basis. What's the difference between Prolo and PRP? How many treatments do you need of each, et cetera, et cetera. So first, we're discussing the treatment of lax ligaments in the neck, including CCI. But again, we could be discussing partial tendon tears. We could be discussing other types of instability, like SI joint instability. So we're just talking about healing ligaments, and specifically in the neck. Now, second, we're discussing very, very different injection approaches between the most common applications of these two technologies. And that's the first thing to really understand here. Let me get a pen. Is if we're talking about Prolo, in general, and this doesn't apply 100% of the time, but let's say 90% of the time, you're talking about blind or simple image-guided neck ligament injections into the supraspinous and interspinous ligaments. And I'll show you visually what that is here in just a little bit. When it comes to PRP, in general, and this is true maybe 70% of the time, we're generally talking about more advanced injections where you use C-arm fluoroscopy to get into specific neck joints, and then you do a contrast confirmation to make sure you're in that joint. So there are some differences in general, doesn't always apply, between how these are applied that make a big difference in what the patient is getting. So here's a visual comparison of what I just said. So the average prolotherapist does these easy, low-skill injections. And this is, again, here I'm going to write Prolo. And they are into the ligaments back here. Now, you can do this with palpation. 2022, as I've said before, I don't think anyone should just be using palpation anymore. You should at the very least have ultrasound to do these simple ligament injections. But you can theoretically do it that way. And then when it comes to PRP, and I'll write PRP down here, again, in general, when I bring that up, I'm talking about hard injections to do that are high skill, that are actually into the specific facet joints. And your neck has facet joints, 2 at each level. They're about the size of your finger joints. So this one I've pointed to here is C1, C2. There's another one up there, which is C0, C1, and then 2, 3, 3, 4 on down. Now, getting into those joints, and especially as we've said many times before, these upper two joints requires much more technical difficulty and much more advanced skills. So when it comes to Prolo with the simple ligaments, I can teach someone to do that competently in a weekend course and feel reasonably comfortable that by the end of the weekend, they would know what they were doing enough so they wouldn't hurt anybody when they went to go and do that in their practice. But when it comes to injecting these facet joints, that's more than a year to learn how to do and to do well under X-ray guidance. So again, there's some very, very different ways that these two procedures tend to be done. And this is not 100% of the time, like I said before. It's about 90% certain that if you're offering prolotherapy and that's what you're calling it, that you do this easy, low skill approach. And about 70% of the time, if you're offering PRP in the neck, you're doing this harder, high skill approach. With only a handful of providers around the US really able to safely inject these upper cervical joints as we've talked about, C0, C1, and C1, C2. Third, prolotherapy and PRP are very, very different products, but they're often exchanged, I find, in common conversation with patients. And so it's a little bit like the zebra colored elephant and an actual zebra. These are two very different animals. But in this case, they both kind of look the same. And so I think that kind of thinking gets to patients sometimes, and they kind of lump these in to the same category, but they're very, very different. So in mechanism of action, first we'll look at this in words, then I'll show you a picture. For prolotherapy, a solution is injected that kills the local cells that it comes in direct contact with, and that kicks off this inflammatory healing cycle. And this is a lot like debriding a non-healing wound. If you've got a non-healing skin wound, let's say because you're diabetic or you're older and you've got a pressure sore someplace, the doctor will go in and pull out pieces, literally killing off parts of the wound in order to get an inflammatory healing cycle started. If you do that enough, you'll eventually get the wound to heal most of the time. Now, PRP is very, very different. Here we've got platelets that release growth factors and exosomes over 7 to 10 days that coordinate and enhance a repair response. In addition, it's also dose dependent. So let me show you some pictures here. So when it comes to prolotherapy, we're causing local damage, and it's chemical damage, and that's kicking off an inflammatory healing cycle. But when it comes to PRP or platelet-rich plasma, we're adding growth factors, exosomes, and other things to the area, and that stimulates healing, and that is dose specific, and that's a very important concept to understand. I can't really increase the prolotherapy response by changing the dose because I'm still going to get local damage, and that's still going to kick off an inflammatory healing cycle. Now, I might be able to increase the dose a little bit, but I kind of get a binary thing. It's either going to kick off a healing cycle of a certain size or it's not. With PRP, I can increase the stimulation of the healing. In the vast majority of patients I see, that's patients that are 35 years or older, based on increasing the dose. So that's a really big difference between these two technologies. Here, I either get healing, yes or no. And on this one, I can dial up the healing knob if you will, from low to medium to high simply by increasing the dose of the platelets. So those are very, very big differences between these two technologies. Now, PRP, you should also know, comes in two types. There's leukocyte-rich, which is red. There's leukocyte-poor, which is amber. Now, of these two, for ligament healing, in general, leukocyte-poor would be the way you'd want to go, or the amber PRP. Now, there are other times, though, if you were going to inject into an intervertebral disc in someone's spine, then you'd want to use leukocyte-rich, for example. So there's reasons to use each. And again, I can't emphasize enough about this dose-dependent response in prolotherapy. And the problem is that we still have clinics out there that are using these useless 1 to 2x concentrating machines, meaning they're only concentrating the amount of platelets either to the amount that's there or slightly more than the amount that's there. And if you're young, that's not a problem. It'll probably still work. But if you're middle-aged or older, it's not going to work. So then we've got other clinics that have these small bedside machines, and they can get into a 3 to 7x zone, so 3 times to 7 times the normal platelet amount that they started with. And that's better, certainly, than 1 to 2x, but it's not nearly as good as someone with a lab can produce when you're getting to 7 to 20x. Because as you get older, again, there's this dose-response relationship. So what does that mean? That means that once you're over age 35 or 40, if this is the PRP dose, I'm going to put PRP here, and the higher here, the more concentrated the PRP, and this is healing, then as the PRP dose goes up, the healing goes up. So we're seeing that, and that's an incredibly important part. Guys, I'm going to have to take just a quick 1-minute break here. Someone's knocking on the doors. Hold on a second. See who's knocking at the door. See who's knocking at the door. Sorry about that. My bad. Okay. And then fourth, the rubber meets the road here between these two is very, very different. And that is the number of treatments that it takes to get to a problem that's solved is different between the two. So what I generally do here is I will look at SI joint instability and talk to patients about how many treatments it's going to take a woman to get into completely healed zone if they have SI joint instability. So for prolotherapy, that's 6 to 8 treatments. For PRP, it's generally about 2 to 4 treatments. And you might say even 3 to 4 as well. So generally about half as much for PRP as for Prolo to get to the same level of ligament tightening. So in summary, Prolo and PRP work very differently. They also produce results in ligament healing at different rates. There are vast differences in how these products are injected. And for PRP, there are vast differences in what's injected between clinics. So the problem, I think, for patients is that they believe these things are interchangeable. They're not. They believe that everyone kind of does it the same way. There is no difference in the sophistication of how these things are being used. Not true. There's a vast difference. And then they also don't understand that even when it comes to PRP, there are vast differences in what it is you're getting when someone says you're getting PRP. So let me stop there and I'll go to questions next. Let me just get rid of all of this. And let's go to questions here. Duck P, if your head feels heavy from weak muscles, can it cause tachycardia? When I get this heavy head feeling, I also experience orthostatic hypotension. I don't experience it when my head feels stable. Well, the belief is, and this is a belief at this juncture because we don't have great research on this, but the belief is that what you're experiencing is when you're unstable. In all likelihood, you're getting some irritation of the vagus nerve. Irritation of the vagus nerve then creates a situation where you get rapid heart rate. You can also get orthostatic hypotension. So that's probably what's happening there. But again, each person is different, obviously. Duck, when using PRP to treat lax ligaments, when do young patients start noticing a tightening effect? Generally, ligament tightening would happen more quickly than tendon healing. So for young patients, I would say 4 to 8 weeks max for PRP. Some people may be delayed from that as well. Duck P, I've gotten prolotherapy a few times. Why is that you notice the stability effect starting after 3 weeks? First 3 weeks, it feels like the Prolo did nothing. That's a good question. I mean, in my experience, prolotherapy can tighten, especially in young patients, as quickly as a couple weeks. So you're probably experiencing some level of increased tightening within the ligament, but then that's going to continue to remodel for quite some time after that. When radiologists report things like there are no prevertebral soft tissue swelling, or there is no atlantodental widening, or they assessing the ligaments with the term soft tissue. Let's just say that if you're reading a report like that, the average radiologist is not looking at in the neck all the ligaments that we would discuss here. In fact, just so that you guys have a good sense of it, if I went and asked, if I just picked a random hospital, let's say large hospital in the United States, has a number of different radiologists working at it, and we got them all in a room from that one hospital. Let's say it's a big hospital, 1,000 beds. So there's maybe 50 radiologists that work at that hospital. And I got them in a room, and I said, guys, here's some MRIs. I want you to find the alar ligament for me. I would imagine that the vast majority, without looking on their phones or without looking it up, wouldn't know where the alar ligament was located. Now, that's not to say anything about their skill level. It's just it's not something they do every day. It's not something they look at every day. And we could go and do that with a number of upper cervical ligaments, and most of them wouldn't know where it was without having to look it up. So it's just not something they do all day, every day. Kimberly, I've had posterior prolo upper cervical anesthesia for set injections, ligaments. How does the pain relief recovery compare for PSL as compared to posterior injections? I know it depends on patient. Seems like going through the mouth would be so much more invasive, painful for recovery. Going through the mouth part isn't really the issue. So maybe, Kimberly, put down there exactly what you had injected previously so I can give you some comparison. But the big difference will be the difference between PRP and bone marrow concentrate. Bone marrow concentrate causes a more stout inflammatory reaction. And so that's the big difference between those two. Thank you. Andy, do you think P2G is a good option for lax ligaments, peripheral joints? Need something stronger than 12.5 dextrose, but don't have access to PRP. Yeah, but Andy, realize that it's hard to modulate that prolotherapy effect because, as I said, it's kind of on or off, meaning that by using P2G, I can kill more cells than I can with 12.5% dextrose. But I'm not going to, which might modulate somewhat the amount of inflammation in the area, but it's not going to be as easy to modulate as increasing the PRP dose. So for instance, in someone who was middle-aged, I can triple or quadruple the amount of healing just by tripling or quadrupling the PRP dose. I can't really do the same thing by going up on the concentration of what it is I inject in prolotherapy. I might be able to change that by 10%, 20%, 30%, for example, by going to a stronger solution that kills more local cells. But at some point, I'm also going to get into that zone where I'm killing so many of the local cells that I may also be weakening the tissue. So again, much harder to modulate with prolotherapy. John, hydroxystenoma here's my question. My dad's 88 years old with severe lumbar pain. He's had a number of steroid injections that don't work for more than a couple of days. Could we expect that PRP would provide longer lasting effect? Surgery has been considered and ruled out due to his age. You know, John, I don't know any clinical history or what's wrong with your dad, meaning back pain is caused by dozens of different problems in the back. So I'd need to see his MRIs. I need to know more clinical information to answer that question. Andy, what's the largest C1, C2 overhang reduction you've seen in a patient that's undergone PICL? On a percentage of C1, C2 overhang, about 50% or so per procedure. Andy, did laser tracking exercise for CCI strengthen suboccipital muscles with the deep neck flexors? More the suboccipital muscles. Now, if you want to strengthen deep neck flexors, there is a type of exercise that can be done there. There's a very specific deep neck flexor strengthening program that can be done if we want to do that. Bethany, Centeno, if disc bulges are treated with bone marrow at the time of my PICL, how long will it typically take to result improvement in the areas in the same time frame as the PICL? Bethany, I think what you're talking about would be more injecting the ligaments and around the irritated nerves. For ligaments and around irritated nerves, that's going to be less time frame for the average patient. So for the average patient there, we might be talking around 3 or 6 weeks versus the PICL at 3 or 4 months. Now, realize that many of my PICL patients obviously aren't average patients. They're essentially sensitized out the wazoo. They've got much more systemic inflammation than the average person. And many have had these problems for a very long time. So it's a different patient set. Submitted advanced by VIA. Can you treat low BDI cranial settling with PRP? Yeah, we don't make that diagnosis in the same way it's made by some of the surgeons, meaning that the concept there is that the head has come down this way relative to the neck. Our focus is on instability. So tightening ligaments to get rid of the instability. As far as measuring static measurements like grab oaks or static BDI, not interested in doing that because that really hasn't been shown in the same ways instability has to be associated with patient symptoms. So very different approach here between those two things. Now, if there's instability in the same patient, then that gets treated through that PICL procedure. If it's certain ligaments and then other ligaments with posterior PRP. WW soft, does needle diameter affect the efficacy and complications of prolotherapy? Can repeated, for example, 9 times in a row injections dextrose cause permanent damage to the ligaments? You know, WW, we don't really do that type of treatment. And there's some clinics that do. There are clinics out there that do, you know, we've seen them do 8, 10, 12, 14, 20 prolotherapy treatments. We don't believe in that concept. If you're not getting better after 1 or 2 prolotherapy treatments, it's time to change to another technology, meaning it's time to upgrade that person, if you will, to something like PRP or go from PRP to bone marrow concentrate. You know, my biggest concern with that many injections is that each injection carries with it, depending on how much guidance you use, a risk of hitting something you're not supposed to hit. Obviously, that risk is much, much lower if you're using very sophisticated guidance like fluoroscopy with contrast injection and digital subtraction angiography. And it goes up if you're using very non-sophisticated guidance, like just turning on a fluoro machine and kind of seeing that you're touching the bone in a spot. And then it goes up from there if you're not using any guidance at all. So that would be my biggest concern, is you want to get the effect that will be accomplished with the fewest number of procedures possible, because each procedure adds a little tiny bit of risk. Again, lower risk if you're using very sophisticated guidance like we use, but higher risk if you're not. So that's the issues I would have there. Now, can injecting a ligament 9 times damage it with a prolotherapy solution? I don't know that anyone knows the answer to that one, and we wouldn't go there. So it's hard for me to even give you clinical experience. I certainly have seen patients come from clinics where they've done 8, 10, 12 different prolotherapy sessions. Are those patients damaged? I don't necessarily see them as damaged, but many times they haven't gotten better. And it's a little frustrating because that's expensive, right? If you do, even if something is relatively inexpensive per time, if you do it 10 times, it gets very expensive. Actually, I have a C5-6 disc bulge that was treated with bone marrow at the time of the PICL. Probably not bone marrow, Bethany. It's probably treated with platelet lysate. So I think I answered that one already. Regenix been advanced by Harry Winston says algo cells do prolotherapy with guidance, of course. Yes, Merry Christmas as well, Harry. You'll have to ask algal cells that. I know that when it comes to doing upper cervical facet injections, because of lack of experience with that, they decided not to do that. But I'm assuming that they offer different types of prolotherapy injections, but that's something you've got to check with those guys. Thatchin, is it okay always to put the dial to high for PRP? It is, but there are certain times when you have practical considerations. So for example, if you had a 50-year-old, always injecting everything with 20x PRP would be just fine. It would stimulate the heck out of healing. The downside would be that you really don't get that much volume, because as you might imagine, it doesn't just take 40 or 20x the volume, it takes 40x the volume to get to there. So if we wanted to inject 5 cc's of 20x, we're now at 5 times 40 or 200 mLs of blood just to get 5 cc's of injectate. As you can see, that gets pretty high pretty quick. So there are some limitations there. But the data we've published so far would show that that stimulating by going as high as you can is a good idea. In older patients and younger patients, it's not needed at all. Regenix mid advanced by VIA. Can you treat the cervical bursa that causes the pressure headaches? I think, as I said, I think you're referring to last week's, or not really last week's. Yeah, I guess it was last week, Friday's topic, where we talked about pressure headaches due to upper cervical bursitis, if you will, or fluid in the upper cervical bursas. There, the goal is to get rid of the instability. And we'll also end up treating the bursitis as well, because we'll get some of the orthobiologic in the bursa. But the goal is to treat the instability, which is what causes the swelling. Jim, can a weak longus coli muscle disuse atrophy cause extra tension to be placed on the posterior ligaments? Yeah, that's a really good question, Jim. So longus coli is up front here, and it's going to be very critical in either bending to look down this way, but when you come back that way, by relaxing and allowing motion to occur in a controlled fashion. So probably not extra tension placed on the posterior ligaments, but certainly extra tension placed on the anterior ligaments, because that's the area that it would control. Sherry Kopp, is prolotherapy safer on the knees than the neck? Would guidance still be needed? Yeah, I mean, guidance in 2022 is standard of care, in my medical opinion. So for the knee, for example, you've got to make sure that you're inside the knee joint, if that's where you want to be. That takes guidance. Let's say we want to inject an MCL ligament. I can do it without guidance in most people that are thin. But once you get any kind of weight on someone, the likelihood of being in that MCL ligament goes down. ACL ligaments, very, very hard to inject without guidance. In fact, it's hit or miss. Maybe you've got a 1 in 10 chance of hitting the ligament without guidance, for example. WW, for young people, is dextrose comparable to red PRP? Is dextrose comparable to amper PRP? Why would reverse and produce different responses to ligaments? So I don't know that I can answer that question the way it's phrased, but in general, for young people, it's pretty easy to stimulate healing. So I think that it would be reasonable to say that most young people, if they had just a small amount of ligament damage, would do very well with this dextrose prolotherapy at 12.5%, kind of the standard dextrose prolotherapy. Now, some young people who had more ligament damage would need PRP. Then we get into the idea of red versus amber, so leukocyte-rich versus leukocyte-poor. Leukocyte-rich PRP is more pro-inflammatory because it has red and white blood cells, which cause inflammation. It's also thought that those red and white blood cells may impact healing in certain circumstances. So the current amount of literature looked at it in its totality would bend towards leukocyte-poor PRP, and its use for most things. Now, leukocyte-rich PRP, since it has those white blood cells and you're constantly concerned about the possibility of stoking up an infection in a disc, would be better for injecting a disc because it's going to be more antibacterial. So I'm not quite sure if that answered all those questions, but I gave them my best shot. Michael, how many treatments for stem cell injections from 0 to 2 are needed compared to PRP in general? So if we're just talking about, so I need to know a little bit more, but I'm going to confine this to something that I can answer. So let's say we're talking about just treating a painful and mildly arthritic joint at C01 and C02 without any instability. So we're just injecting intra-articular into those joints. PRP works well enough in that instance that we rarely use bone marrow concentrate or stem cell injections, as you're probably terming it, in those joints. Now, if we had a more severe arthritis, again without instability, then it would be reasonable to consider bone marrow concentrate. How many injections in the first instance for PRP? Mild OA within the joint, 1 or 2 max. But again, that assumes that we're putting in high-dose PRP, and that assumes that we're treating someone who's got some age on them. So let's say a 40-year-old, and that assumes 14 to 15 times concentrated PRP. Now, if we take that down to 5x PRP in a 40-year-old or 3x, which is what a lot of clinics would produce, then all bets are off. Not going to go that same direction. Mark, can you give a detailed explanation of what happens in the 6 to 8 week timeline after a procedure at the time when the body is taking the disorganized collagen and organizing into new ligament tissue? Is there some breakdown of original ligaments during this process? Is it possible to see a temporary worsening of symptoms at this time period? It seems to me I typically get worse around 8 weeks to 16 weeks, so they seem to heal more slowly than others. Yeah, so I think what, Mark, you're bringing up, and this is an important thing for people to understand, is that first we've got the inflammatory phase of healing. And that means that there's swelling and inflammation in this case, a ligament. Now, what you're describing is further down the road when you actually start to get reorganization of the collagen. So initially, new collagen is laid down in the second phase, and it tends to be disorganized. But as the area is loaded, it tends to organize into a stronger, denser structure. Is it usual for people to get worse during that time? It's not. And it's not so much breaking collagen down, although there's some of that that's happening in real time. It's reorganizing the tissue that's there. And again, not common for people to get worse during that time, but it may happen in someone who's a slow healer. Adam, MRI shows a pinched nerve at C6-7 and multiple disc bulges. I have some mild dizziness as well. Will PRP help with this? Well, dizziness is almost never related to C6-7. It's usually related, if it's related to the neck, and it may not be, to the upper neck, C0, C1, C1, C2, C2, C3. So can PRP help with nerve root irritation due to a disc bulge, let's say at C6-7? Sure, we treat that all day, every day. But your dizziness probably has nothing to do at all with that level, because that's not a level that causes dizziness. Fatchin, what is different by C1, C2 facet injection, Dewey, caps, or ligament? No such. I think, again, Fatchin, what you're talking about is the terminology used by prolotherapy guys is that they are injecting the facet capsules. It's total bullshit, meaning they're not injecting the facet capsules at all. Hate to put it that way, but they're just sort of putting the needle somewhere in the vicinity of where the facet capsule might live. And I think what you're talking about is the difference between that sort of blind or semi-guided approach and actually putting something in the joint versus actually trying to inject the facet capsule, where you can document under guidance that you injected the facet capsule. And those are three very, very different approaches. In the first one, you're kind of putting the needle somewhere in that vicinity, not quite sure. In the second one, you're injecting inside the joint. So you're getting the inside of the facet capsule and the cartilage. And in the third one, you are specifically guiding the needle into the facet capsule and then are documenting that's where you are before you inject something. I got that here. Kimberly, thank you. I had C0 through 7 ligaments and facet injections. Facet joint injections, Prolo. Yeah, Kim, that doesn't tell me what you had done, so I'd need to know a lot more than that. Maybe start with who did it, and I'll probably know what they did. WW, does dextrose hurt less than various types of PRP and stem cells? Dextrose and leukocyte poor PRP are about the same in what they feel like. I've had both done. And bone marrow concentrate, which I think is what you mean by stem cells, tends to be more pro-inflammatory and causes more post-op discomfort in most people. And that's because most people have a problem with systemic inflammation. Now, for the people who don't have any problem with systemic inflammation, it's probably not a big difference between those three. I think I got that one already. Bethany, why do CCI patients have thoracic pain even though there's no damage in that area on imaging? Well, some CCI patients have referred thoracic pain, and that can be referred from the lower cervical spine. But a lot of CCI patients have separate thoracic problems that we identify and treat, most of which aren't identified on imaging per se. But if you relook at the imaging, you can usually see clues from the MRI, for example, that show why they hurt in a specific area. Michael to WW Soft. Yeah, we'll generally knock people out for a bone marrow aspiration. But if the bone marrow aspiration site is numbed up appropriately, it's pretty comfortable in the vast majority of people, but we'll generally knock them out. Not quite. Okay. Jim, how many of the physicians that currently work at your clinic, Centeno-Schultz, can perform C0 through C2 facet injections? Everyone that works there can perform those. They were taught those. And, but again, there's the difference between I can perform it and I'm really good at it because I do it all day, every day. And again, it's something that patients generally have a hard time understanding. I think they believe that doctors aren't human. And so when you're taught something, you just can instantly perform it at some later date at the same facility and at the same level of expertise as someone who does it all day, every day. And you can't. So that's sort of the big issue here with these procedures. There's I got taught how to do it, and I do it sometimes, so I'm okay at it. And I do it all day, every day, and I do this 500 times a year, so I'm really good at it. I've dialed it in to the point where it's in that level of mastery. And I think that's the big problem for patients to understand is that going someone that does C0, C1 injections, and they've only done it 20 times in their whole career, and they've been working for 20 years or 10 years, is always going to be higher risk than going to someone who does 500 of those a year. The problem is there's no one on earth that does 500 of those a year outside of Schultz and myself. Ryan, with CCI, is it common to see patients with little to no neck pain, headaches, but many autonomic symptoms? Not common. We would call that atypical presentation. So we certainly see patients like that, and those are much harder patients to diagnose and treat because, well, we rely on lots of different things having to do with problems in the upper neck, like headaches, tenderness in those joints on exam, certain nerves being irritated, headaches, etc. Pain at the base of the skull, things like that, in order to help make a CCI diagnosis. So it certainly makes it a lot trickier if those are the only symptoms. And then we always, in those patients, have a lower certainty of diagnosis because of that. Meaning that the likelihood that we're making the wrong diagnosis in a patient who just had a traumatic injury 6 months ago that could cause CCI, that has, or their EDS, that is tender only in the upper cervical spine. They've got instability on a DMX that fits. They have the response to treatment that fits. They've got headache, dizziness, pain in the upper neck is high. But when we start getting into, they don't have any of that at all, and they've got POTS, digestive issues, and brain fog. The problem is that we're now at dozens of things that could cause POTS, digestive issues, and brain fog, only one of which could be CCI. WW, is diameter, shape, and sharpness of the needle is a factor in efficacy? I don't think it has to do with the efficacy as much as diameter of the needle is usually directly related to the expertise of the provider. And what I mean by that is that providers using, let's say, ultrasound, for example, that are really not sure of their skills, tend to use really thick, big needles because they're easier to see under ultrasound guidance. Providers who have a lot of experience in doing ultrasound tend to be okay with much smaller needles that do less tissue damage and hurt less because their skills are good enough where they can easily see the needle despite it being very, very small. Selena, when doing PIC on the upper neck, is it possible to do injections in the mid-neck and right shoulder? PRP done in the mid-neck, the shoulder, still having specialist right shoulder. Oh yeah, Selena, we often will treat the whole person. Now there's a caveat there, right? If we've got someone who is not a fragile leg, meaning someone who has no problem tolerating these kinds of procedures, then we can treat whatever other body parts we need to at the same time. But if we see someone who's in that central sensitization category, i.e. a fragile egg, where getting a massage caused them 2 weeks of pain, then we're not going to do that. Then we're going to stick with as little treatment as possible. So it depends on the person. But yes, other than those sorts of issues, we generally like to treat the whole person rather than just one spot. Ulysses, do you help people improve posture? Yep, we do. In fact, I usually give multiple posture lectures a week. If anyone's been in the office, you probably have gotten one or two over the time that I saw you. Anya, can the joints between the thoracic spine and the ribs and the ligaments around them be injected? Can rib facet joints located close to the sternum be injected? Will this help with pain and instability? Yep, do it almost every week. Let's see, this last 30 days, I've probably done and treated what you're describing as you're describing it at least 6 or 7 times, maybe 8 times. Maybe not that much, maybe 5 or 6 in the last 30 days, something like that. But yes, pretty frequently. Let's see, how long does prolotherapy last? Can you get it every 2 to 4 weeks for 3 to 6 months? I wouldn't recommend, I think what you're describing is what I was talking about before, which is this concept of clinics that inject, that do 8, 10, 12 prolotherapy sessions. There's really no rationale, in my medical opinion, to do that. You should, if you're going to start with prolotherapy on ligaments, then great, do 1 or 2. And if you've not gotten home run results, then it's time to switch to something else like platelet-rich plasma, which has a bigger effect than Prolo. But injecting someone every 2 to 3 weeks, 10 times, is not something we would ever do because there's a small amount of risk with each injection, as I was saying before, and you're just magnifying that total risk by taking that approach. Dana, can you reach the posterior lino-occipital and lino-axial membrane and ligament and the joint capsule for AO with posterior PRP? Yes. Diana, will red light therapy post-PRP speed up healing? No one knows the answer to that one. Selena, can upper neck issues cause ringing in the ear and things sounding underwater, sinus issues, and jaw tightness? Will the PICL help with these symptoms? Hearing is tested as normal. Well, ringing in the ear or tinnitus is a symptom that we've seen go away. So that's the good news with treating upper cervical instability. Sounding underwater, that one is possible that it's related to upper cervical issues through various nerves, but it also could be related to things like the temporoauricular nerve here behind the jaw. And jaw tightness, TMJ in general, is a common one with upper cervical instability. So we'll generally treat that. Either TMJ or just treat the upper cervical instability, and that will generally either go away after we treat the upper cervical spine or we treat the TMJ directly. Diana, with posterior PRP injections focused at Caesar, will help the sensation of skull slide forward and back. Yeah, Diana, I would need to do an exam and all the rest of that to answer that question. Are there ligaments that control that motion at 0-1? There are. I think, as I may have mentioned previously, also measuring the depth of the occipital condyle, because there's a way to measure that in an equation, trying to make sure that it's not too shallow, because there are some congenital things that people are born with, i.e. a shallow occipital condyle, that can make what you're describing worse. Dan, I did well with dextrose prolotherapy below C2 is indicative of success with posterior PRP. I think that's a pretty good metric. Diana, if I do cold water therapy up to my abdomen, will this affect PRP in my neck? I know icing is not good, but will cold water therapy lower down the healing or backfire? I don't know, Diana. I don't know the answer to that one. I think this concept of cold treatment is relatively new, not really that well researched at this point, and more of a social media than medical phenomenon. Diana, if we wear our soft collar while walking post PRP as the neck is healing, will this put too much tension on ligaments during healing? No, but just realize that, as I always say, wearing a cervical collar is a two-edged sword, right? On the one hand, it may help symptoms, make someone feel better, but on the other hand, it can also cause weakness in the muscles, and stability is half muscles and half ligaments. So if we tighten the ligaments and you don't have strong muscles because you're constantly wearing the collar, or if you've got a lot of muscular atrophy, then the hole, so to speak, the hole that you have to climb out of to get well is being dug deeper and deeper by the collar use. Jim, is DNF training using pressure biofeedback, which you're referring to? Yes, it is. Also, are we strengthening the upper cervical muscle fibers at 0-3 since we're doing craniocervical flexion? Upper cervical muscle fibers at 0-3. Lots and lots of muscles up there. There's about 5 or 6 on each side in the back here. So I'd need to know which of those you're talking about. Diana, any supplements to avoid before posterior neck PRP? And is copper supplement needed for ligament support? The biggest one to avoid would just be any kind of supplement that could cause increased bleeding. So fish oil, you probably want to stop for 2 days before, for example. As far as a copper supplement, if you're taking a multivitamin or you have a good healthy diet, I don't think you need to supplement with a special copper treatment. Kim, Dr. Williams with Regenix. Okay, well, that at least tells me a little bit more about what was probably done. And you had asked, I'm just going back here, Kim, to what you had asked since it's been a little while. Sorry, we got fire engines out there. I think you were asking about recovery and would it be worse? So in general, I think just to be on the safe side, if you're a patient that was able to tolerate what Dr. Williams did with not anything more than 3 to 7 days of increased soreness, then I wouldn't be too concerned about PICL recovery. On the other hand, if you're the kind of patient who was flared up for weeks and weeks before you got better, after what Dr. Williams did, then you should be concerned about PICL recovery, and we should have that conversation for sure. WW, if Prolo people do not inject the posterior capsules, what exactly do they inject? In general, are they hitting any important valuable ligaments, tendons, muscles? Yeah, it's a good question. Without precise image guidance, it's very, very difficult to say what it is they're injecting many times. In general, what they're taught to inject is what's called Hackett points. So Hackett points are just points along the posterior elements or lamina, and in the middle where those supraspinous, interspinous ligaments live. If you're doing that blind, how often do you get into, for instance, supraspinous, interspinous ligaments? 60-40 maybe in the right patient, 70-30 in a really skinny patient, and 50-50 in a patient that has any weight to them. So what's normally injected there? There's some tendons that are injected. If you're in the right spot, you can get the ligaments in the middle. And every once in a while, you probably pick up a facet joint capsule. But I think that's the whole point, right? It's that you want to target something and specifically inject that structure rather than the shotgun approach. Rigolab, what can PRP, BMC help with in a case of thoracic outlet syndrome caused by tight overstructure, sarcopenic scalings that tend to cause arm, chest, shoulder, and headaches? Scalings generally don't cause headaches. So again, it depends on what's causing the scalene tightness. Usually we'll see scalene tightness from cervical instability. Sometimes we'll see scalene tightness from scoliosis and a side bend in the spine. So it all depends on what's causing those tight scalenes and what we're doing to try to help that problem. If we have, for instance, thoracic outlet happening from scarred down parts of the brachial plexus as they go through the scalene muscles, then, for instance, something like platelet lysate hydrodissection under ultrasound guidance can be very helpful. Outside of that, you're really talking about what's causing the tight scalenes to begin with and treating that thing. John, anyone you can recommend for simple Prolotherapy PRP to the nuchal ligament occipital ridge tendons in the Newark, New Jersey, Pennsylvania area? It's Dr. Brian Scheipel, a good bet. Brian's a sports medicine doctor without spine training, so I think I would look for someone who has more spine training. You might look at Paul Lieber in Pittsburgh, for example. That would be a good one. You can just go on the Regenix site, and if someone is listed as doing cervical spine on the Regenix site, that the only way they're allowed to do that is they have formal interventional spine training. So that would be just go to Regenix, REGENEXX.com, go to find a provider, and then look for someone in that area who's listed under cervical spine. Because since I'm the one that decides who gets on that network, they won't be listed as cervical spine without having interventional spine training. And if I find that one of our network providers that doesn't have interventional training is doing cervical spine, I'll throw them off the network. So you can take that to the bank. WW, is tissue damage caused by a needle different from tissue damage caused by dextrose? Yes, quite a bit. So dextrose would kill anything, well, hypertonic dextrose, meaning 10 to 15% dextrose, will kill any of the cells very quickly it comes in contact with. A needle will just cause local damage. If it's a small needle, less damage. Bigger needle, more damage. Dana, AO has helped some neurosyndromes, but made me bobblehead worse. Dana, I think I need some more information there. I think maybe there was a wrong word in there. Robert, are there different levels of Regenix training? For example, do all Regenix treat 0 or only some? Yeah, at this point, we authorize no Regenix providers outside of Colorado to treat 0-1. So there's not a single Regenix provider out there that I would recommend at this point to treat 0-1. And that has to do with the risk involved versus the number of procedures that they can amass doing that. It's just too high risk based on recent data. So there's a huge difference there between providers. For instance, we've got providers that only do peripheral joints. We've got providers that do some simple lumbar spine. We've got providers that do the whole spine with simple injections. We've got providers that do the whole spine with more complex injections. And we've got providers that do 0-1, and the only place that's recommended for that at this point is Colorado. I don't recommend any other Regenix site at this point to inject 0-1. Bethany, can a motor vehicle accident 4 to 5 years ago cause CCI that was only now causing symptoms years after the accident? It's possible. Diana, can someone with shallow condyle still do okay with posterior PRP? Sure, it just means that there's less of a physical structure there to support what's going on. So that person is going to be more ligament dominant. So the bony structure is not assisting the ligaments. Sure, Michael. WW you make reference to specifying different schools of thought in the practice of prolotherapy. Are there more than 2 different pivotal camps in prolotherapy? There's certainly many, but I think I'm not quite sure which 2 schools of thought you're referring to here. So I think what I've talked about is that you've got blind prolotherapy and what I would call simple image-guided prolotherapy. There's also other schools of thought. So if you could try to expound on that so I can answer your question better. Levon, hydroxy does fasting for 28 to 48 hours or more yield higher stem cells compared to standard. Levon, we don't know that one. No data. Kimberly, do you have shockwave treatment after your procedures? I had a session done and it really helped. I wouldn't recommend that for CCI patients, but for other things, shockwave can sometimes be helpful. Sheila, why does looking at screens and overstimulation make my headache worse? I would need to know more about your clinical condition, but certainly looking at screens can be difficult for patients who have CCI simply because it can impact the way their eyes work. But that's something that I'd need to know more to answer. Levon, after DMX is performed, do you recommend to visit an AO? Oh, I'm sorry. My bad. Skipped ahead. WW, can upper cervical chiropractors exacerbate or cause upper instability? Not that we've seen. Generally, the types of chiropractors that seem to cause upper cervical instability, and that's a pretty rare event, would be kind of the long lever, turn the whole head quickly kind of chiropractor. And that's definitely not NUCA or AO. Levon, after DMX is performed, do you recommend to visit an AO to get the atlas aligned prior to PICL? Dr. Rose advised the atlas should be aligned prior to injections. Yeah, either before or after. Either one is fine with us. Yeah, Robert, again, this is something that's hard for patients to understand. Listen, Dr. Scheipel is a great doctor. I've sent patients to Dr. Scheipel that have issues in their knees and shoulders and ankles, but he's not interventionally trained through a standard set of information, something like the Spinal Injection Society, and those sorts of things. So it's a different thing altogether, a different level of understanding into how those procedures are done, et cetera, et cetera. So we're just talking about 2 way different levels here. And it's a hard one to relay to patients who aren't involved in seeing how providers are trained on a day-to-day basis. So I wouldn't refer a 0-1 patient to Dr. Scheipel based on that. But again, I'm not referring 0-1s out to many people these days unless that person is doing an awful lot of them on a day-to-day basis. Diana, AO made bobblehead worse, but helped neuro symptoms. I have atlas osteophyte as well. Possible AO made me more aligned than actually stabilized me. Hard to say, Diana. I think the biggest thing and problem we see with AO is simply that it's very, very technique dependent. And if the vectors are right on, people tend to do well. If the vectors are off, people don't. Okay, guys, it's 4 after, and I've got a 2 o'clock meeting, so I'm 4 minutes late for that 2 o'clock meeting. I'm sure my meeting's like, where the heck is he? So I'm going to start shutting this down. Let's see. We have this coming Friday, which will be before Christmas Eve. And I think I'm going to take some time off here during the holidays. I'm going to be working in the office seeing patients, which is unusual for me, just because of my time away schedule with sailing. So I will end up taking some time off. So I think this could be our last one of these for a while until just after the holidays. So I probably won't be here this Friday or Monday because that's going to be in that holiday time frame, and then we'll take it by ear from there. But thank you so much. I want to wish you all a Merry Christmas, Happy Hanukkah, whatever it is you celebrate. It's one of my favorite times of the year. It has been since I was a kid. And I really appreciate you all for asking some great questions today. And again, keep asking these great questions, because answers and understanding what these questions mean and what their answers are really helps people get much better healthcare in this crazy system that we have. So have a wonderful Christmas, Hanukkah, whatever it is you celebrate. And I will see you after that. Thank you.